Thank you, Ashley, and thank you very much, Angela Polanco, with whom I've worked a lot on parent and patient involvement in improving outcomes and research. And I've listed a long list of things of what I do just to say really the perspectives I want to bring, which obviously as a practicing paediatric oncologist, worked for many years at the Royal Marsden, previously worked in Newcastle and Edinburgh, and most recently I've been at Great Ormond Street Hospital and have some interaction, though non-clinical, with UCLH. I've been the chief investigator for the National Renal Tumour Studies in the UK since 2001, and because we recruit at almost a near population level, I think that gives us a very good handle on what, where there are potentially, what does good quality care look like for that particular diagnostic group. I also have a role as Chief Medical Officer for the providers of cancer care for all ages in North London, so that's a population of 3.5 million, and we're now part of what's called the National Cancer Vanguard, which is all about innovations to improve cancer pathways, from improving prevention where possible, earlier diagnosis, through reducing variation to improving support for patients living with and after cancer treatment. I also have European connections. Again, I've been working at the European level with SIOP for many, many years, and during my time on the board, we have developed European standards of care for children's cancer centres, and I've been involved in working with cancer population-based cancer registries to understand and analyse international outcomes, which are currently mainly limited to survival. So I think, we saw it as a lovely video from Click Sargent, but, I can imagine the mother of that child and the child themselves, when they're old enough to understand, they know there's something seriously wrong. You've never encountered it before, so you're a complete stranger, and if you like, you're at the mercy of the healthcare professionals whom you see, and I think you can have a high level of confidence in the UK that you're going to meet an excellent team who absolutely are resourced and empowered to do what's best for you and your child. But everybody wants to think about, is this treatment going to work? Is the treatment going to be the best one, right first time, or is there a chance the tumour will come back, and what will happen if it does? Have I been offered the very best personalised treatment for my child, including the sort of support throughout that treatment, things like, one parent inevitably is having a hard time because they often have to give up work, so the whole family's under stress. And there's always, even from the point of diagnosis, concerns about, you want the treatment to be as effective as possible, but you also want it to be as safe as possible, both in the short term, so there's a very low risk of your child dying or having a very serious episode, say in intensive care, but also you want to know that the treatments you've been offered minimise the risk of causing long-term side effects. Some questions are much more difficult to answer, like, why has my child got cancer? We do know in a few cases and conditions that there's quite a high contribution from genetic predisposition, but in the main we don't know why most children get cancer. Where there is an established genetic risk, of course, one can then apply advice and testing to other members of the family. And I think really I wanted to focus on the last point, which is, how do you have confidence that you and your child is being treated in the right place at the right time by an expert team? And that may vary even throughout the treatment trajectory according to what it is your child needs. So where do we start? So back in 2000, so for a start, the CCLG itself is part of quality standards and improvement and has been in existence since 1987, am I right, Ashley? I ought to know. It's a long time anyway. It's more than that, 1977, sorry. And there are similar societies of healthcare professionals interested in childhood cancer care right across Europe and North America and in Australasia and increasingly now in Africa, India and elsewhere. And I think those are important drivers of being aware of what the standards should be and ensuring that the centres to which children with cancer are referred for diagnosis and treatment comply with those standards. But the UK was amongst the first in Europe to actually produce very detailed guidelines for what you should expect in a principal treatment centre and a shared care, recognising that there's big geographies involved and that some elements of care can be given closer to home wherever possible. But the overriding principle of the NICE Improving Outcomes Guidance published in 2005 was to have high quality care, so as high a quality as is possible and needed, and then secondarily as close to home as possible. So you don't compromise quality in order to deliver care closer to home, because the rarity of the condition often means that to get the expertise and the volume going through a service, it can't be round the corner. Now, in 2008, so 3 years later, a very long book was published with all the measures. How do we know these services are actually delivering these standards? If you open it up, this is just the first of several pages of the index. Every one of those lines is a measure, and all the children's cancer centres and the shared care units were asked to produce evidence that they comply with the standards in each of these. So you can imagine a huge amount of work, quite bureaucratic, nearly all related to process, staffing, have you got the right people, facilities, and so on. But it probably didn't tell you very much as an individual about what your chance of being cured by the treatment you're being offered, or how likely it is you might have a chemotherapy side effect or something. That's not the sort of information that's in these things. But one would hope that alongside having high quality expert teams across multiple disciplines in good quality facilities, that your child is going to a place that's got the best chance of looking after them properly in a kind and caring way and with a good outcome. More recently, NICE is sort of changing its approach to how one lists quality statements. These were put on the website, so these are all accessible publicly. These were published in 2014. There's lots of statements which I'm sure you can easily agree with. Everyone can have these slides afterwards, so you don't need to read the details. But if you drill down into them, you then start to see measures of how the data can be captured. Now, you've probably heard about this thing called peer review. So going back to that long book with all those lists, it used to be that every year centres would have to produce lots of evidence, and they'd actually get a visit, not necessarily every year, every other year, by something called a peer review team that will come and actually independently ascertain that the evidence for the provision of that aspect of the measure was actually taking place. Now, I can imagine that's pretty resource intensive. And also, because a lot of peer review is process measures, there were some questions about, does it really tell you, what's it like as an experience by the family and the patients? Is it really telling us that these centres are giving the best possible chance of, say, safe and appropriate surgery, high quality radiotherapy, etc.? Because those types of things were not really measured by these process measures. So what the NHS is doing now to keep an eye on quality, we now have the quality surveillance team, who are part of NHS England. And they want to, so the NHS is getting better at producing data and being able to collate it. And we want, wherever possible, to use routine data from the hospitals to be able to say, can we use this to both benchmark institutions against each other and know that they're providing high quality care. So it's now called the Quality Surveillance Team, and it's an integral part of the approach to improvement. And I think, knowing what it is you're doing, the types of patients you're treating, and how your service compares with other similar services in the country is a very important part of benchmarking and continuous improvement for staff. We also have, at a national level, a specific clinical reference group for cancer in children and young people. And the current chair is Dr. Rachel Hoff, who's an adolescent haematologist based at University College London Hospitals just down the road. Now, as part of this QST, trusts are required to do an annual self-declaration. So against those quality indicators, which still include lots and lots of process measures, they have to say, do they feel they meet the standard? And if no, then they have to say why. So at the moment, they don't have to upload reams and reams of documents to prove they meet things. But the chief executive of the hospital has to have an internal process in each trust, because he or she has to sign to say, I agree with this upload by this team. And this doesn't just apply to children's cancer, it obviously applies to adult cancers as well. So the chief exec or his delegated authority has to be assured internally that what they're putting in this self-declaration is true. But actually how they oversee that process in each hospital is determined locally. So this is the kind of quality surveillance team's workflow, and what you'll see is that there's routine surveillance that I've just described. They may pick a particular area, particularly if there's local concerns for enhanced surveillance, increased surveillance, or even a peer review visit. But these, so if a parent, if they received several communications from parents about a particular service saying they'd had problems, I guess that would mobilize them to think about going to actually physically visit that unit. But bear in mind, all of this is relatively new, and pediatrics, the entire pediatric cancer services did a special self-assessment earlier last year and earlier this year, because we are now doing a national review of childhood cancer services across England. How are these data, when they are collected, presented so people so health professionals and also parents and others could look at them? So what they are now in the process of getting together for specialized services are producing these things called dashboards. So you get a sort of line of the whole countries, and the trust for each indicator will get at what's called a spine chart, which will show where their trust is in relation to the England average and the kind of range of what's felt to be acceptable. But of course, this depends what they're measuring. So what are they planning to measure at the moment? And again, I'd be interested to know your thoughts on how much you feel these would reflect a good quality service. But for example, if your child needs to go into hospital and cannot be accommodated within the children's cancer ward, but ends up being what's called an outlier, maybe the only bed in the hospital is in the ENT department. Obviously, that's not optimal care, because the nurses looking after that ward during the day and overnight won't be experts in children's cancer. Of course, they can access the other nursing expertise in the hospital, but it's probably not quite the same thing. And there's things now about, patient survey responses and so on, and we are in the process nationally of having a patient experience survey for children and young people, which Click Sargent is very much involved in driving. The other aspect of high quality care in childhood cancer, and this is probably true of any rare cancer, is that you would expect to be offered enrollment in a clinical trial at the point of first diagnosis. This doesn't mean that your child has got a really difficult cancer that nobody knows how to cure, because we're constantly trying to optimize how we use the current treatments we use, which again, the Click Sargent little girl cartoon very nicely illustrated just how scary and horrible many of those treatments are. So if we don't need to use them, or we only need to use them for a subgroup of patients with a particular cancer type, the way we do this is by enrolling everybody at the point of diagnosis in a clinical trial. The treatment that most of them get may just be standard of care, but they may give permission for additional, say, tissues to be studied for gene markers, imaging to be reviewed, and so on. And a new thing that's coming in, well, it shouldn't be new, but having a very comprehensive and useful end of treatment summary with a follow-up care plan is also part of proper high-quality cancer care at all ages. And again, documenting that is happening is probably the challenge, and I'll be interested to know how well it is happening across the country. Now, a lot of these metrics are being put out now in the National Cancer Dashboard. Again, this is publicly available. Here's the website. And for many adult common cancers, you can look by geography. That's a clinical commissioning group geography, or by a hospital. And you can look at breast, lung, colorectal, and prostate cancer individually. But for rare cancers, they obviously only show you aggregated data. So the only thing that's on there, and you can also look at trends over time, the only thing that's on there for children's cancer currently is 5 years survival for the whole of England. And this shows the point by year. So you can see, although it's going up all the time, from 1 year to the next, because we're talking about rare diseases, you sometimes get a dip, and that's not statistically significant. It's just variation, because the individual types of cancer proportionately will change a little bit from year to year. But again, this is being developed, and there'll be more and more on that going forward. But I still really fundamentally believe, how long have we got, 5 more minutes? Okay. That clinically, to really understand, are we offering children in Britain the best possible diagnostic and treatment pathways, international benchmarking, because we can't get the sort of benchmarking that we need internally. Probably on safety issues, things like, right type of surgery in the right place, we might be able to do that as a nation. But to know if we're really doing the best thing for survival rates, even within a country the size of Britain, actually looking at survival by centre is fraught with all sorts of problems to do with case mix, small numbers, and so on. So this shows you the vertical, this is Europe with population-based cancer registries, and it excludes brain cancers because the comparability of brain cancer diagnosis categories in population-based cancer registries is very variable across Europe. And what you'll notice is that the UK and Ireland, so this is 5-year survival, all cancers except brain cancer, is just 2 or 3% lower than some of the best that have been reported in Europe, in France and Germany. So there is a small, and it is statistically significant difference. But the question is, what can possibly cause that? Well, obviously there could be patient factors. Maybe children get too late to the cancer centre, the tumour's already more advanced, so there's a difference in tumour stage between countries at the time of diagnosis. It could be due to population factors. And certainly if you compared the UK population to, say, Japan, there's quite a lot of ethnic differences in the types of cancers we get and how aggressive they are. Subtle, but they are there. But within Europe, that's probably not the explanation. And of course, the most important thing is, what are the health service factors that may potentially contribute to this? Or is it all about routes to diagnosis and tumour stage? And currently, population-based cancer registries hold very limited data on the stage of the tumour. So that's, stage 1, 2, 3, 4, 5, depending on the tumour type. So this is just all cancers, and it may be that one of the reasons is that and we know this in some cancer types, we have more advanced stage in neuroblastoma and renal tumours in the UK compared to Germany. But the reason we know that is not because we've been able to compare population-based cancer registry data, but because we've been able to compare very detailed clinical data that's collected as part of a clinical trial. So this shows you the result of a decade's worth of data collection in a clinical trial in which the UK participated, along with Germany, Brazil, France, and this is most Western European countries. And what the black line is the volume of a Wilms tumour at the time of diagnosis. And then the rest of the line is the range. And what you can see is that the UK has bigger tumours at diagnosis than the other groups. And when you look at the survival in this trial, there is a very small but statistically significant difference in survival between the UK and Germany. And in fact, all of that could be ascribed to the fact that the Wilms tumours are bigger, because we know that there's a certain characteristic of Wilms tumour. You have lots of the most primitive elements called blastema present at diagnosis, and they don't shrink with chemo, that you've actually got a worse biology tumour. So although I can't, absolutely 100% nail it, that's probably likely to be a big contributing factor, because we do also know that children actually get to medical attention pretty quickly in the UK. So there are lots of steps in a cancer patient's journey that can be improved through research and better use of data and benchmarking. And this sort of concept's called cancer intelligence. And it includes, what happens before you're even diagnosed, whether there's screening available for your cancer type, and obviously that's important in retinoblastoma and certain genetic conditions. Diagnosis, treatment, that can be a loop. Support in survivorship, and quality, of course, is also important if you are not going to be curable, that your quality of remaining time of life is maximised. Now, Public Health England, about 5 years ago, migrated all of the children's cancer data into a single database to which they can link all of these types of data, so that we've got a fantastic resource now to do research and quality improvement and really drill down and understand our services. But the challenge is getting this data collected at the clinical coalface in a complete and high quality way, and in a way that is interoperable technologically with this. So there's lots of holes in the data at the moment. It doesn't mean the data isn't there, it's just it hasn't been collected in the hospital in a format that's accessible to put it in the national database, but we have plans to improve that. And the first example in childhood cancer is retinoblastoma. There are only 2 treatment centres They're working with NCRAS to make what we call an enhanced data set. The clinical centres will collect detailed data, including data about the parents, because this is a tumour type with a high genetic component. And there'll be a sort of firewall on the personally identifiable information with some of the other data that comes out, but it makes this not only a very useful clinical database for care and treatment, but also a research database. And I think many of you in this room probably know Chris Carrigan, who has really driven the fact that using data is helping to save lives because it helps improve quality of services and also in understanding where the gaps are if they exist. And I think having the parent and survivor voice behind access to personally identifiable data that's coded and used and accessed in a very carefully controlled way is enormously important, because the regulators and data protection is getting ever more bureaucratic and therefore expensive to enable this type of research to be done. At a European level, we published a European Cancer Plan for Children and Adolescents in 2015. We're now working to get our 7 major objectives addressed in every single national cancer plan in Europe. We're also building some enabling platforms. There's now a quality assurance project for pediatric radiotherapy across Europe. We are part of the European Expert Reference Network in childhood cancers, which involves international tumour boards where we discuss the very rare cases. And I've got a major responsibility to help us move forward on what's called outcomes research using detailed clinical and biological data. This is the cross-border healthcare European directive, several institutions, and it led to a pilot called Expo RNet, which had strong support from the International Childhood Cancer Patient Group. And the aim of my own leadership in the outcomes world is to try and merge or bring together much closer joint working between these 3 sources of data, so population-based cancer registries, routine health records in the hospitals, and then the trial data, so that we can actually use them for research and quality improvement and bring them all together. And I'll stop there. That's okay. Thanks.